Well, wonderful. Those were incredible presentations. We are running a little bit late, but I think we can take a few minutes for some questions.
Just a quick announcement for the virtual audience. We will have the virtual poster session, which is virtual only, starting after the panel discussion. So we'll not start until after the panel discussion. This was a separate link that you received through email. Thank you.
We're going to take some of the questions from the audience. There's two questions. This looks like it's related to EP. How do you demonstrate bidirectional block after cable tricuspid isthmus ablation in a Fontan? Can you please describe the catheters used? And then if pulmonary vein isolation alone is good in a Fontan population or diseased atria, how good is it alone?
Yep.
For Dr. Folansby.
Am I on? Can we hear me? Oh, right. Yeah, this is an excellent question. This is, again, where the advancements in technology have really helped us out. So we are predominantly using EnSite X during our ablations and using the HD grid catheter, which essentially, to quickly describe it, looks like a fly swatter with a bunch of different electrical sensors on it. By using that, we are able to position that over top of our areas of block, and in live pacing, using usually a quad catheter position somewhere else in the atrium, we're able to demonstrate live flow of electricity across the myocardium and demonstrate the deviation of the electrical flow around our ablation area to prove the existence of a effective line of block. And then as far as the PVI goes, it's a very interesting question. You know, the literature is not there yet for how good the PVI alone in this population is going to be. I think the very large adult studies looking at PVI in the traditional adult population has taught us that there are a lot of pitfalls and surprises awaiting us down the line as we learn how to apply this technique to the adult congenital population. But certainly our early experience has been encouraging in the short run as far as freedom from recurrence of atrial fibrillation goes. Though with the caveat being also that in the setting of the multiplicity of IART circuits, needs to be assured that revolving either figure 8 or multi-insert ART circuits are not confused for atrial fibrillation circuits.
Wonderful, thank you. There is a question about cath. Do you always look for venous collaterals from the hepatic and renal veins in a Fontan cath, or only when you suspect?
Great, thank you for the question. I think this is a pretest probability-driven experience for sure. So desaturated patients get more detailed investigations than patients who are well saturated. I would say we typically include an angiogram in the IVC or azygos, depending upon the anatomy, and then typically another angiogram that is at the hepatic vein confluence adjacent to the entrance to the lateral tunnel or to the extracardiac conduit, but deeper investigation is warranted in patients who are more desaturated. Hope that helps. Thank you.
There is a specific question. There's a couple of questions actually addressing the CLIP interventional structural therapies in AV valve regurgitation. One is about what do you do with the hole in the extracardiac conduit if that's something that ever has to be closed. And the other one relates to timing as an intermediate step prior to transplant.
In our limited experience, we have not closed them. Eventually, they do close. Mm-hmm. But obviously, if there's cyanosis, you can always go back and close them. And then to answer the last question about transplant, I think what is my ideal patient? My ideal patient, when we're discussing them, is a patient with Fontan, good hemodynamics, or good ventricular function, and has prolapse, definitely repairable valve. And that's the kind of patient you talk to the surgeon. Can we give it a try with a clip? And obviously, you have to be the advocate for the patient in the procedure and make sure that patient doesn't leave unless they have an excellent result. Because if you deploy a clip and it's a suboptimal result, you may make it harder for the surgeon to repair the valve.
That makes sense. Makes sense. Wonderful. We may have to answer some of those questions electronically afterwards, but I wanted Tarek to ask you, with the MRI becoming such an amazing tool to assess patients with Fontan, and unfortunately we have so many patients who can't get MRIs because they have pacemakers or stents. How do you go about still getting the best data from MRI on patients who have stents, for instance, or what alternatives do you see in terms of advanced imaging so that we don't have to take all these kids to the cath lab?
Yep. Thank you, Jackie. That's an excellent question. I'm biased, but I think MRI is a great tool in this population as well. But I think about 15% or so will have a pacemaker, which will, currently we can't scan them in the MRI scanner because they have epicardial leads, and that's a contraindication for cardiac MRI. So in these patients, we end up doing a CT scan. And with the newer CT technologies, we can do like retrospective CT with relatively low radiation dose, which will allow us to assess ventricular function. So to do a lot of similar things to MRI, except for the flow data. For anatomy, that's also very good, so we can identify if there are any collateral vessels easily by CT as well. And then for the stents, most of the newer stents are, generate just low artifacts, so we can still scan them by cardiac MRI.
That's wonderful. Thank you. Thank you. And maybe for Dr. Malik and also for you, Tarek, about as well as Libby, what are the recommendations to screen the liver in Fontan patients? What kind of protocols do we use, both in children and adults?
Yeah. So, go ahead, Dr. Malik.
So it's a little bit controversial right now. The current guidelines just recommend surveying cirrhotics. And I think that's generally what we're doing based on either a biopsy measurement or an elastography. I'm not convinced about the data on HCC and non-cirrhotic Fontan patients. I think the data is a little bit sketchy. But generally, most of us are defaulting to some type of imaging study within 6 months to a year with an AFP.
Yep. And I can speak to the pediatric patients. We start some screening around the age of 12. And that's based on the youngest patient who was reported with hepatocellular carcinoma, which is the age of 13 or so. Mm-hmm. And we do that infrequently in childhood, and then we increase the frequency as we get to adulthood.
Wonderful. On that same line, there is a question from the online about any medical therapies to slow Fontan-associated liver disease, and whether aldactone has any role in that.
So there is data not in the Fontan patient, but in patients with other forms of fibrosis, coffee. So if you guys like coffee, there is very strong data on coffee and regression of fibrosis. I don't know how the cardiologist may not like that. So a little bit of
coffee, a little bit of wine, and you can counteract each other and not have any bad effect.
But the next big wave in liver disease, of course, are antifibrotics. So hopefully in the coming years, we'll see something like that.
Wonderful. Yeah, I think we may have to wrap up now. You want to wrap it up? Yes.
Thank you all the speakers for great talks, and we look forward to sessions in the afternoon.